Thank you so much for inviting us to present. Actually, I heard that I volunteered, and given COVID, I'm not surprised that I volunteered and didn't even know I did. But COVID-19, Louise and I are going to present some information on COVID-19 through a sex and gender lens. So in 2016, Dr. Sabra Klein, who's referred to as an immunofeminist, with Dr. Katie Flanagan, reported in Nature Review Immunology that male and female differences in immunological responses are influenced by both sex and gender, with sex contributing to physiological and anatomical differences that influence exposure, recognition, clearance, and even transmission of microorganisms, and gender reflecting behaviors that influence exposure to microorganisms. There are 216 key points reiterated that changes are influenced by sex hormones, including estrogen, progesterone, androgen, and to the differential regulation of the immune system. Sex differences in immune response result in, and I quote, differential susceptibility of males and females to autoimmune responses, malignancies, and importantly, in the case of COVID, infectious diseases, as well as affecting the outcomes of vaccinations. Fast forward to 220, where in their seminal paper in the Canadian Journal of Public Health, Ahmed and Damansky note that global data suggests that despite similar rates of infection, SARS, the virus responsible for COVID-19 pandemic, hospitalization and mortality rates are higher in men than in women and across all age groups in confirmed cases. Sex disaggregated data tracker data through the Global Health 50/50 has noted that while the exact contribution of sex, which are biological attributes, or gender, which are socially constructed roles, behaviors, and expressions, and related factors will shape the outcome and is still unknown. An understanding of the influence on each is of urgent importance in the COVID-19 pandemic response. 3 distinct sex differences for acquiring COVID-19 have been identified, and they include the immune system differences, ACE2 enzyme levels, and comorbidities. The immune cells from females are more reactive and generate a much more robust response. Adult women mount a rapid and aggressive innate and adaptive immune response to combat evading pathogens. With contrast, men have dampened immune responses and are more susceptible to viral infections. The X chromosome is encoded with more genes that control the immune function. And there's also a process called hormone signaling that's different for men and women, where estrogen is responsible for altering the signaling inside an immune cell, and it coaxes the cells to start or halt, making the proteins in an inflammatory response. Angiotensin II is an integral part of the RAS system and is a functional receptor that allows SARS-CoV to invade the alveolar epithelial cells. Sex differences in ACE expression are not clear. Males have a greater RAS activity than men. However, Virose et al. Reported that ACE2 is ubiquitously expressed and exerts protective effects in the cardiovascular system, lungs, kidneys, and guts. And indeed, symptoms of SARS-CoV are intimately linked with the expression of ACE2. Comorbidities, well, the mortality risk has been increased in those with cardiovascular disease, diabetes, obesity, and elevated D-dimer, with speculation that higher burden of CVD and thrombosis in men may be contributing to greater number of deaths. Early data from China demonstrated increased mortality among men. Indeed, it's become the predominant message. However, the prevalence of reported sex disaggregated cases varies extensively by country, suggesting that social, economic, and cultural factors influence not only the acquisition of COVID-19, but patterns of testing for suspected infections. The issue still remains that countries, including some Canadian provinces, are not consistently reporting sex disaggregated data. As noted here on the Global Health 50/50 website, the rose-colored sections represent countries who do not have sex disaggregated data. It's important to point out that of 192 countries reporting COVID data, only 14 provide sex disaggregated testing data. 26 out of the 192 provide hospitalization data that's sex disaggregated, and 18 out of 172 provide the ICU data that you see here. Just over half present data by sex disaggregated data by sex. Numerous factors, including age, ethnicity, race, socioeconomic position, geographic location, occupation, all intersect with sex and gender and will shape the vulnerability of the impacts to COVID-19. Interestingly, the global 50-50 data report that of the countries that report sex disaggregated results, females are more likely to be tested. However, there are equal numbers of cases identified in males. Globally, males are more likely than females to be hospitalized, be admitted to the ICU, and die. For every 10 females confirmed COVID cases who die, there were 15 confirmed males. Again, this is globally, and this is in the 26 cases, countries that reported hospitalization, ICU, and death data. One of the issues we identified in our paper in CMAJ was that sex disaggregated data, even when provided, was also based on country-specific sex disaggregated testing data. As you will note, there are large variation in the testing of males and females by sex. In Canada, the deaths from COVID are equal between men and women. However, there are significant differences in the sex disaggregated data along the clinical pathway, with males having higher frequency of hospitalization and ICU admissions. While the sex disaggregated data reporting hospitalization and death outcomes is sparse, there is data being collected that will help elucidate the sex and gendered factors. The iCare study, initiated by Dr. Simon Bacon and Kim Lavoie of the Montreal Behavioral Medicine Center, is an international assessment of COVID-19 related attitudes, concerns, responses, and impacts in relation to public health policy. The iCare study captures key data on people's awareness, attitudes, behaviors as they relate to the COVID-19 policies, as well as impact of COVID that COVID is having on people's physical and mental health. As collaborators with the iCare study, further work will be directed at addressing the sex and gender differences in awareness, attitudes, behaviors as they relate to the COVID-19 pandemic. iCare's most recent sex disaggregated data demonstrates significant sex differences in the mental health impact of COVID-19 and clearly suggests that there are gendered factors that will require further exploration. Furthermore, access to care, a variable known to be gender related, identifies sex difference that warrant study. Well, what about gender differences? Gender refers to socially constructed norms, roles, identities, and behaviors typically ascribed to women, men, and gender diverse individuals. It can also refer to the relations among individuals based on gender or the institutionalization of these norms. Importantly, in our own work, we constructed a framework in an attempt to tease out the gender factors that at a minimum require further investigation. Gender influences an individual's exposure to infection through occupation in essential services, risk-taking behavior, and employment of precautions. Gender has an impact on an individual's ability to seek and receive testing and care through norms of health-seeking behaviors, responsibilities at home or work, reduced availability of health services, or institutional biases. I would be remiss if I didn't mention Going Forward, Gender Outcomes International Group to Further Wellbeing and Development, which is composed of a large consortium of Canadian and European researchers. Our overarching aims are to integrate sex and gender dimensions in applied health research and to evaluate their impact on clinical, cost-sensitive, and patient-reported outcomes in non-communicable diseases. In March, like the rest of the research world, we turned our attention to assess the influence of sex and gender-related factors on the relative male-female burden of COVID-19 to gain a better understanding of the risks and impacts of the pandemic. However, we quickly discovered there's no consistent country-specific COVID-related sex or gendered factors collected. In our study, The Influence of Sex and Gender Domains on COVID-19 Cases and Mortality, we considered whether the distribution of cases by sex reflected a gender-related inequality by testing for an association between the measures of institutionalized gender equality at the country level and the sex ratios of COVID-19 cases. To measure institutionalized gender inequality, we used the United Nations Project Gender Inequality Index, the GII, that reflects the distribution of sociopolitical power and resources. It's calculated using relative proportion of men and women employed, the proportion of men and women who attain higher education, the proportion of women in parliament, and the reproductive health in terms of teen birth rate and mortality, maternal mortality by country. The GII is standardized so that 0 indicates perfect gender equality and 1 perfect inequality in favor of men. Given the availability of the data, we were able to consider gender as a binary to discuss the social norms traditionally ascribed to men and women. This figure shows that the calculated male-female ratios COVID-19 cases to countries. Overall, the higher a country's gender inequality favoring men, the greater the proportion of males among reported cases compared with females. So aside from using indices like the GII as proxies of gender, what do we know about the gender differences in general? From the WHO report on the influence of sex and gender, we know that gender influences both patterns of exposure, with women more likely to stay home to infection agents, and the treatment of infectious diseases. Gender roles influence where men and women spend their time, the infectious agents they come into contact with, as well as the nature of the exposure. Differences in the provision of healthcare to males and females, as well as in accumulated scientific knowledge about the effects of treatments, influence in the course of outcomes for those who have been infected. Specifically in Canada, we know that women comprise 82% of healthcare workers across Canada, putting them at higher risk for exposure to the virus. Social distancing and self-isolation pose major threats to women as intimate partner violence rates increase. Prior to COVID-19, more than 1.9 million Canadian women lived in a low income, a number which has risen the economic impact of the pandemic and devastates sectors that employ a high percentage of women, including in education, restaurant, hospitality, and social services. The Canadian Centre for Policy Alternatives reports that 56% of women are employed in the 5 Cs: caring, clerical, catering, cashiering, and cleaning. In fact, the RBC report done by Desjardins and Freestone on March 4th, 2021 report that almost 500,000 Canadian women who lost their jobs in the pandemic haven't returned to work as of January 2021. Before the crisis, these women held a wide variety of jobs, but there was a common thread, and I quote, "Many worked for modest pay in low-skilled service jobs that helped keep the broader Canadian economy humming along. They were highly visible in food courts, salons, and pubs, and elsewhere, places that didn't allow for physical distancing when the pandemic hit. Because women represented the majority in industries most affected by the virus, they bore the brunt of the job losses." In fact, COVID has highlighted gender role differences that will affect the health not only of families, but of the Canadian economy. Women have been reported to take on 70% of the unpaid responsibility at home. They shoulder a heavier burden when the pandemic added homeschooling to their load. In the last year, 12 times as many mothers as fathers left their jobs to care for toddlers or school-aged children. As I alluded to earlier, sex stratified data with gendered factors continues to be scarce, if not unavailable. However, even with the limitations to the data that we are now able to use, the learnings regarded from the influence of sex and gender on testing, acquisition, and treatment. Now we are in the vaccination stage, and moving forward, it is imperative that sex and gender factors are considered in identifying priority groups for COVID-19 infection vaccination campaigns, especially in females. As a result, the Going Forward group, led by our postdoc student, Dr. Zara Azizi, completed an important study, which will now be presented by my colleague and friend, Dr. Louise Pilote.
Thank you, Colleen. So in the 5 minutes or so that I have left, I would like to present to you some empirical data that we've been trying to put together to assess the question as to whether there are sex and gender factors that would highlight or give some information about vaccination strategy. So we performed a sex stratified analysis using machine learning in the UK Biobank database that we had access to. So our objectives were to examine sex and gender related factors associated with SARS-CoV-2 test positivity, and to examine sex and gender related factors associated with SARS-CoV-2 related hospitalization. And then based on our results, we wanted to see how we could influence the recommendations concerning COVID-19 immunization prioritizations. So the UK Biobank, for those of you who don't know, is a retrospective cohort study. It has 500,000 participants, and it collected baseline data in 2006 and 2010 in 22 centers across the UK through touchscreen data acquisition and verbal interviews. And in 2020, from March 16 to May 18, the UK Biobank linked with the PHE, the Public Health in England. And then we were able to get data on COVID-19 infectivity, infection rates, and also hospitalization. So these were our endpoints for our study. So we did perform with this very vast database, a machine learning approach, where we use gradient boosting machine that to build prediction models. And then, in fact, in machine learning, most people are interested in building models and finding the best prediction models, but we were really interested to find in those models what were the most influential variables for COVID infection acquisition and also for hospitalization. So we developed models for males only, for females only, and also for overall males and females. But these were the only dichotomy of gender identity that we had, and unfortunately we had no other measurement for the gender identity. So the flow chart, just so you see, it's really small on my screen here, but basically of the 500 or so thousand UK Biobank individual aged between 40 and 65, there were 4,510 patients who were tested for COVID. Of those, it was about half and half, males and females. And on the left-hand side, you see that there were 31.6% of COVID positive patients who were males, and then 27.3% of females were COVID positive. Next slide. So the variables that were utilized in the analysis in the UK Biobank are really extensive. We had some comorbidities type variables on the left-hand side, and I provide you with the list here. And just to say that in identifying risk factors for COVID infections, we've been using, in general, in the literature, the usual paradigm of comorbidities. And then, the prioritization of vaccination has been based, as with other vaccination policies, on comorbidities. We also had several gendered variables that were available in the UK Biobank, and they're listed here. And these include things like the housing ownership, household crowding, number of children in the household, some of the risk-taking behaviors, some of the employments, and so on. And then there were also some more biological variables on the right-hand side that were measured as well. So this was about 34 or so variables that were put into a machine learning model to find out, the best predictors. But here I'm going to tell you more about the factors that came out as the most important in risk prediction for COVID infection. And on the right-hand side, focus on males first. We see that it's similar to what has been reported in the literature. More biological related factors, body mass index, obesity, with obesity, high cholesterol, alcohol use, health score, and ethnicity. So these are more biological related factors, according to the definition that Colleen has given us earlier on. But surprisingly for females, we saw that there were more psychosocial factors that came out in terms of the most important factors: environmental score, night shift, obesity came, number of people in the household, and income. Just to say that environmental score is actually, just to define that, is the environment in which a family lives in terms of access to services. This is a score of deprivation that is measured in the UK Biobank. And for hospitalization, the factors were quite similar, in fact. So once a person had the infection, the risk of hospitalization in terms of maybe severity of disease was quite similar between males and females. But to mention that for females, again, housing score, that has to do with deprivation based on where the house is, and the poverty of the dwelling is a risk factor for hospitalization. So next. So Next. So this is just showing you these two, well, can you go back? These are two tables that show the model performance. Like in machine learning, we want to know how well the models performed. So these are the usual measures. And although in general, the models that we had performed moderately well, one point is that, we were able to identify the risk factors both for males and females. So that was for the model performance result for the predicting infection. And the next one was for the hospitalization. So just because we don't have much time left, I'll conclude next by saying that, when we think about proper vaccination prioritization, which will allow for more effective control of transmission, we should take into account gendered psychosocial factors in addition to comorbidities and biological factors. And this came very evident to us when we saw that the factors that were associated with infection were more biological factors in males, but in females, they were more gender-related factors, social determinants of health that were appeared to be determining infection in females. So I think in going forward to vaccinating the population at large, we should focus on sex-related factors if we want to reduce morbidity and mortality, and these include low income, night shift workers, high density households that should be given priority. So on that, I will end and we'll open this for questions.
Thank you so much, Dr. Norris and Dr. Pilote. We'll go straight into the question and answer period. We have about 5 minutes, and there's a couple of questions in the box. So I will start by asking the first one, which is, does the gender analysis work to include Two-Spirit here on Turtle Island? So I think this is referring to the Indigenous populations.
I mean, clearly we would. Oh, Louise, you're muted.
Go ahead then, Colleen.
I was just going to say, clearly we would love to include all of the aspects of gender that are possible to include. It just is, the data isn't even collected necessarily as far as sex is concerned. We can't even identify the males and females. So absolutely, yes, it should be part of the analysis. It's just, right now we're trying to deal with the data that we have available to start looking at those things.
But certainly we've been advocating, at least for sex disaggregated data. Like earlier on in the pandemic, we reached out to every editors of every major journal. And then we said, you should request when you report data that they're disaggregated at least by sex. And you should also request that, gender psychosocial factors are also assessed in the determination of risk as well. And then, we see the result that we got. We unfortunately don't have much data, even when we just want to look at, sex, males and females. We have nothing else on other gender identity variables.
Thank you. And we have one hand up at the moment, Dr. Sasha Bernasti. Sorry if I mispronounce your name.
Oh, that's okay.
Yeah.
So I really enjoyed Louise's presentation, and she knows I'm a fan of hers. But she ended by commenting on that we need to think about the vaccination priorities, and I guess because currently the vaccine is being rolled out and is going according to age strata, which is maybe not a bad idea, and that age operates among regardless of gender and sex. Age is probably going to remain as one of your important factors in terms of risk and outcomes of COVID. But I would say what may be an even larger role for these for the analyses that Louise presented is that, wouldn't it be interesting to hook into the vaccine hesitancy issues and try to show people who have vaccine hesitancy, if they do have some of these risk factors, if they're working night shifts, if they have some, because there's a lot of vaccine hesitancy sometimes among disadvantaged populations. So I think that could be a really good hook to say, look, these are the facts, and this is why it's important for you to choose to get vaccinated if that's their choice.
Well, I can answer that question. So I think your right age is a good way to prioritize, but now we're, at least in Quebec, we're down to like 65 or 60. So now we're going to prioritize the general population. And what we're trying to say is that, please, for once, use priority that will help people at risk. And this appears to be sex-based. So, in Quebec, go in Montreal, go, to Park Extension and go to the poor neighborhood, and start with that, because crowding and poverty and certain jobs that tend to put women more at risk. And also, men and other family members, should be prioritized. So I think, social determinants of health for once should be used to prioritize as opposed to the biomedical model. So that's one thing. And then with the eye care data, I think we will be able to answer the questions you're asking about vaccination hesitancy, and look at the sex and gender factors and occupation in the gender types of variables to see which ones are related to vaccine hesitancy. So that's a good point, and I think we'll be able to look at that with the eye care database.
Dr. Norris, would you like to respond as well, or continue on to the next question?
Continue on. Yeah.
Perfect. So the next one we have here is, how do the sex-specific risk factors for hospitalizations due to COVID-19 compare with the typical risk factors of hospitalization in general between males and females?
So that's one of the most interesting things to me as we start going through this data for those that do provide sex disaggregated results, that there are different, typically we would say the reasons for hospitalizations. I mean, if you were to ask anyone on the street, it was, well, they already had diabetes or they were obese, which is what the data did demonstrate for men. But that's not necessarily the case for women. And to me, it kind of reminds me of the work I do with women's heart disease, is that, women present differently, and it stands to reason they present differently in COVID as well, and that maybe we should be paying more attention to gendered factors and look at evidence that is suggesting that there are gendered factors that get you to hospital for women, and there's sex factors that are getting you to hospital for men. So Louise might want to add something to that.
I just want to say that, in terms of you're saying in terms of hospitalization for COVID versus hospitalization for anything else in general. So, social determinants of health are associated with, worse health and more hospitalization. Whether they vary between males and females, I think it remains to be looked at. This is one example where COVID has allowed us to push the boundary of research and then really looking at, the impact of, asking for sex disaggregated data and really putting the psychosocial maybe over the biological. I mean, that's what we would like, because at the end of the day, this is really an important determinant of health, and COVID allows us to, put it to the forefront, the social determinants of health. So just wanted to add that.
Okay, great. Well, we're out of time now, but it's 4:31, but I just want to thank you both on behalf of the CanCOVID team and network for presenting to us on such an important topic, and we've generated such a great conversations. As you can see in the chat box, there's lots of questions there too. So we hope that this was a great session for everybody. I just want to just note that next week is the next speaker series, which will be on March 23rd, and that will be on the puppy study, which is by Dr. Emily Marshall. So hope to see you all there, and have a great rest of your day. Thank you all. Bye-bye.
Thank you.